Tag, you're it. Medical and health's role in emergency response. Episode 2. All disasters are local. The community responds. Once evacuated from the danger zone, directing or transporting people to the right place is very important. Patient tracking and the communication of this information to the health and medical partners is critical.
I don't know all the stories about how the evacuation happened, but I do know some of those stories. So Enloe and Adventist ambulances were taking patients from the hospital down the hill to other hospitals. The staff here at Feather River Hospital were doing the same thing. At skilled nursing facilities, the kind of heroes of the situation really were the staffs in those facilities. I have pictures on my phone that show piles of burned gurneys and wheelchairs outside of skilled nursing facilities. And it's obvious what was happening from those pictures, although we've heard the stories as well, that those staff members, often people whose own homes were at risk, sometimes their own family in peril, took those patients, put them in their cars, and drove them down the hill. That's primarily how people got out during the Camp Fire.
The role of the ambulance strike team has kind of changed over the last couple of years in these incidents, and really we look at them as a multi-role resource. Again, at the early stages, they may be used for helping support shelter operations and providing medical care in those type of aspects. We use them for evacuation of medically fragile patients, skilled nursing facility patients, and there does need to be a significant amount of coordination that goes along not only with the local EMS system, but also our partners in the medical health system as well. Once the ambulance strike teams were actually in place, which happened within a few hours of the initial request, then obviously we incorporated them into the system and they assisted us with moving patients from skilled nursing facilities, assisted living facilities, and hospitals to other appropriate facilities where they could have continued adequate medical care provided.
Healthcare facility evacuations are complicated and often dangerous for fragile patients. Local public health and medical partners must work together with first responders to move patients swiftly and appropriately. Emergency management teams at the California Department of Public Health, CDPH, and the Emergency Medical Services Authority, EMSA, work with local partners before, during, and after emergency healthcare evacuations. Health and medical partners must work closely with emergency managers and nonprofit and community-based organizations, CBOs, such as the Red Cross, churches, and food providers to establish and operate general population and medical needs shelters.
There are many shelters with plenty of room. Their doors are open, just waiting for Camp Fire survivors.
We've had shelters in lots of different types of facilities. Because we have contracts with the churches, the county EOC was able to set up shelters like almost immediately with our social services staff and Red Cross volunteers that were on site. And then because we knew very early that we were going to need to have a med health presence, we started just calling in our nurses to begin being there along with the logistics staff.
In our experience, not just in the Camp Fire, but in the spillway incident, people come to our shelters, but if they have any other option at all, they will quickly choose those options and not remain in shelter. So you're left with the most vulnerable people that are still in your shelter. Even 48 hours in, I would suggest we have already kind of self-selected for a very high-risk population. A population, I will say that it is surprising to me that they are able to successfully live at home. Nearly every shelter a couple of days in is a medical shelter as well.
People won't evacuate if they can't take their animals with them, or they won't separate from them when they're in the shelter. And there's been, times where, people will sleep in their cars in the shelter parking lot so that they can stay with their cat or their dog. And that is often really challenging. The rules and things have changed over time. And so we're looking more at co-location of having, small, especially the smaller animals. So dogs and cats, co-location of those facilities with a human population shelter. So really working on promoting and educating communities about preparing for the animals is huge.
So we had many local churches and faith-based organizations that provided housing for people who weren't going to shelters, provided food and clothing, not at the shelters, but at their churches. We did have organizations throughout the state and the country coming, not Red Cross volunteers, not mutual aid, but other nonprofit organizations offer to assist. And so we had working with disaster healthcare volunteers and other vetting organizations, being able to make sure that people with licenses that were coming were who they said they were and would be able to be scheduled as part of our schedule.
So in all of our recent large-scale wildfire incidents, the Oroville Dam spillway incident back in 2017, we had significant communication and coordination with these type of entities, with faith-based organizations, non-governmental organizations, the Red Cross. They assist in setting up and managing disaster evacuation shelters. They assist in providing resources. They are an integral part in the response and coordination of multi-casualty incidents and disaster incidents.
Emergency management and medical and public health emergency response plans, guidelines, and requirements have evolved over the years. California's existing disaster response frameworks have been tested and tried many times over the years. Adherence to these long-standing processes is vital for success in disasters.
Prior to 9/11 and prior to anthrax attacks, historically, public health was really not part of emergency response in California. Now, we have evolved a lot from bioterrorism. Our emergency management folks will be looking to public health as the subject matter experts and inserting us into EOCs. Sure, we'll have a field level response in some cases like we did with contact tracing and investigation in COVID, but many times we're going to be in the EOC, so we need to be comfortable in that role, field role, as well as an EOC role. And that's something that 20, 30 years ago, public health was not part of, that we are now an integral part of.
I think that adhering to frameworks like SEMS, NEMS, the State Emergency Plan, really gives you the ability to work across agencies, across disciplines, across jurisdictions. And the reason for that is you have a common language, you have a common set of expectations, you have common structure, whether it's how an EOC is set up or how field incident commands work or how resources are requested. All of that is standardized and the nomenclature is standardized so that if I'm talking to somebody in a different discipline and we're using the same terminology, we're going to be a lot more effective. So it's really important for that standardization and that understanding of how the systems work to make things work the way that they're supposed to.
There are going to be large counties where the health officer is not going to get involved in this at all. They have staff members that are the MOAC. There are going to be counties where the health officer is very part-time and not available, or in all honesty, not very well trained and familiar. And in those counties, I think the important decisions, some of the important decisions you need to make ahead of time are, how are we going to respond? Is this our responsibility or is it not? And if it's not ours, who have we then communicated and delegated that responsibility to? And those are reasonable answers. It's just, you don't want to be making those decisions while the fire is burning. You want to make those decisions ahead of time.
Regarding the plans and the documents that are prepared by the state and available for local jurisdiction use, those are definitely great resources to have. But again, in the midst of an emergency, hopefully you've already acquainted yourself with your role and the resources that are available, how to access a resource. You don't want to be learning this as you're responding. You want to be familiar with those resources ahead of time.
I think the emergency operations plan was helpful before the event in preparation more than it was helpful during. I think that it helped frame conversations and responsibilities in a way that we began the discussion internally and with our healthcare partners prior to the event. So some of the meetings and exercises that we had, I think, were triggered by some of the things we read in the plan. During the event, at least in the early hours, you are busy. And so the chance that you're going to pull something off the shelf at that point is, at least in my experience, is small. But anything you are able to internalize and bring with you ahead of time is useful. And relationships that you build because of it are useful.
The most important thing you can do is develop relationships ahead of time. It's so important. We know who is who well before the disaster. Have those phone numbers in your phone.
We had to do what we had to do. And now I'm getting to the final word of the day, which was maybe innovation and flexibility. To be brief and blunt, you have to be flexible, you have to be innovative, you have to find ways to respond, hopefully within the network and guidelines that we have on our desks, but sometimes you have to find new avenues to be able to deliver a solution. And I'll use the example of the Tamarack fire that we had. We had 200 people evacuated and registered and show up in a shelter. We have three shelter sites in Alpine County. Within about 10 or 15 minutes, all three of them were in evacuation zones and unusable for us. A phone call was made to Douglas County across the border in the state of Nevada. They have a large community center where they feed seniors and so on, and they welcomed us with open arms and staffed it with their CERT, Community Emergency Response Team. They staffed it for us. I provided the medical director component of that. We had to do COVID screening in the middle of it. Environmental health had to come in and deal with the food. Our nurses and staff had to deal with registration, screening people as they came in. What are your medical needs? What prescriptions do you need refilled? What oxygen or whatever medical supplies do you need while you're here? Behavioral health had to come in because these people were evacuated, didn't know if their homes were intact or not at that point. Champus, which is a community organization, came in and fed us royally every night. Salvation Army provided food for us after Champus was no longer able to do that. American Red Cross came in and assisted us. And churches oftentimes not only provided places for people who weren't in the shelter where they had facilities, but many people in the community are familiar with the churches, are already part of the churches, and look at those as safe places to go. And so where that was an opportunity, they could go ahead and house and feed people and sometimes take people into their own homes. And this happens in rural and frontier communities probably a lot more than it does in an urban setting, but everybody takes care of everybody else. That's part of the nature and the advantage of living in the communities that we work in.